Good afternoon and welcome everybody to the Health and Adult Social Care Scrutiny panel on Thursday the 19th of August. I'm Councillor Habib Zaman and I'm the chair of the panel, and if I can ask members of the panel to introduce themselves. Councillor Afak, do you want to introduce yourself?
Thank you, Chair. Good afternoon, everybody. My name is Councillor Afak Butt. I'm the councillor for Hetman Dwight Ward.
Councillor Leslie Warner.
Yeah, good afternoon, everybody. I'm Leslie Warner. I'm a councillor for Colne Valley Ward.
Councillor Fazila Luna.
Good afternoon. I'm Councillor Fazila Luna for Batley East panel member.
Councillor Bill Armour.
Yes, hello, Councillor Bill Armour, Kirkburton Ward.
Lynn Keedy.
Good afternoon, everyone. I'm Lynn Keedy, a co-op team member of the Scrutiny panel.
David Rigby.
Good afternoon, it's Dave Rigby here, and I'm a co-op on the panel.
Okay, and we have with us Peter Bradshaw. If I could introduce Peter. Many of you who have been been panel members for a number of years will recall that previously Peter Bradshaw was a co-optee on this panel. He's been a professor in health policy for the University of Huddersfield. Peter has extensive knowledge and experience in this field of health and social care. His contributions to the work of the panel has been invaluable and has helped to shape significant elements of the panel's work. Peter is no longer eligible to be a co-optee because he no longer resides in Kirklees. However, due to the nature of the work of this panel and the complexity of many of the issues it covers, I'm pleased to inform you that Peter has agreed to attend meetings in an advisory capacity and to utilise his knowledge and experience to help inform the discussions. I'm sure you'll all enjoy me in welcoming his attendance at this meeting and future ones, and look forward to his contribution. We also have members of the panel, and we also have officers in attendance who are going to join us throughout the panel. And if I can ask them to introduce themselves. Helen Hunter from Health Watch.
Hi everybody, I'm Helen. I'm the Chief Executive at Health Watch Kirklees and Health Watch Calderdale.
Okay, it's Stacey Appleyard.
Hi everyone, it's Stacey Appleyard. I'm the team manager at Health Watch Kirklees.
Thank you. Have we got everybody? David, do you want to introduce yourself?
Sorry, is that for me, David Birkin? So I'm David Birkin and I'm the medical director at Calderdale and Huddersfield NHS Foundation Trust.
Okay, and Suzanne.
Hello everyone, I'm Suzanne, Director of Workforce and OD, also at CHFT.
Thank you. So if we can move on to...
Habib, we've also got Mid Yorkshire as well, don't forget.
Okay. Who have we got from Mid Yorkshire? Sorry, I can't see the names.
Thank you, Councillor. I'm Andy Smith. I'm Associate Medical Director and Clinical Lead for EPRR at Mid Yorkshire Hospitals NHS Trust.
Thank you, Andy. Is that everybody covered? Okay, so if we can move on to minutes of the previous meeting. Are they a true record?
Happy to agree.
Second. Thank you. Any interest which councillors may wish to declare, you can sign the form and return that to Richard after the meeting.
Councillor Zaman, is it possible that if they do have an interest publicly, if they could just confirm what that interest is now, please?
Okay. Anybody got any interest to declare? Leslie?
Just to say that I am a executive director for the NHS Trust, that's all.
Thank you. We have no admissions of the public, and we have no deputations and petitions, which takes us on to item 5, public question time. We have no questions from the public at this meeting. And number 6 is impact of COVID on a Kirklees Acute Hospital Trust. So we have 2 hospital trusts. We have the Mid Yorkshire Trust here, and we have the Huddersfield Trust as well. We've received papers from each of the trusts and the presentations, which are attached to your agenda papers. If we have, if we can go straight onto discussion, onto questions, if it's okay with both the trusts, rather than going into the presentations, unless you want to give a very brief introduction to the reports that are attached to the agenda papers.
Councillor Zam, can I just clarify, there was some additional information regarding Dewsbury that I think Mid Yorkshire were going to report on. So can I suggest that they just report that verbally first, and then we can go into questions, if that's okay?
That's fine, yeah. Do you want to move on to doing that?
Okay, thank you, Councillor Hurban. So people will be aware, because it was released in a press statement, that unfortunately we've had to reduce our activity at the Dewsbury site on our surgical side. That has resulted due to the increased pressure in the trust on acute beds, which has resulted, unfortunately, long waits in the emergency department, also impacted on the ambulance service offloading patients in the emergency department. There are several factors to why that pressure remains or is there, and that is, unfortunately, high attendance to the emergency department in excess of the normal, so high numbers of attendance, a longer average stay in hospital by patients. That's increased by 0.5 or half of a day per patient, which times that by 700, that's 350 bed days. And the challenge around our medically optimised fit for discharge patients being moved back into the community. So it's very important, obviously, we can care for our acutely ill patients. So we had to free up some space to be able to try and mitigate by moving the medically optimised fit for discharge patients to the Dewsbury site. And therefore, the 30 beds, which is Ward 12 and Ward 14, are now used for that purpose. On the operative side, obviously that has reduced the day surgery that takes place in the Ridings Theatre. To try and mitigate the impact of this, and I say it is a decision that none of us wish to take, but to mitigate that, we have increased the day case numbers on the Dewsbury site. So the impact is not as big as it could have been. As reassurance, no cancer surgery is done at the Dewsbury site, and our P2 urgent patients that were due to be operated on the Dewsbury site have been moved across to the Pinderfield site. So hopefully it's not impacting, and so far it hasn't impacted on the urgent P2 patients. So it has reduced our overall capacity, but hopefully mitigated. And for our pain service, etc., alternative arrangements have been put in place. This is through a 3-week period to be reviewed. This has been reported at the Chair of Command. There's very much a letter has come from NHS ENI, the importance around this being a system response to try and mitigate the continuation of this. There has been for the Wakefield here, because the highest number of medically optimised beds that are unfortunately blocking acute beds are predominantly Wakefield patients, but there are a number of Kirklees patients. There has been appointed a executive lead from the local authority to support that into the integrated discharge team, and a considerable amount of work and efforts being placed in there to optimise how these patients that are medically optimised fit for discharge can be moved out to the acute bed base to enable us to return back to full activity, as per the presentation I submitted prior to the meeting, showing that actually the trust has done really well to maintain its numbers, and we are operating at the high number for making sure that we're maintaining our service delivery for our cancer and urgent patients, and that number hasn't dropped off compared to our normal activity. As I say, this will be reviewed, and it's a whole system response to look at this, to how we can ensure the appropriate patients are attending to our emergency departments. But there is an increase in higher acuity of these patients attending and therefore requiring admission. But making sure emergency departments can work effectively with no long waits in the emergency departments. And as I state, a significant amount of work with the system to enable that patients that are optimised for discharge leave the trust in a timely manner, so we can keep our acute bed base opened and allow the flow through the system. With the intention in 3 weeks' time to review this and hopefully return back to the model that we had submitted in the presentation. Happy to take any questions.
Councillor Zaman, I don't know if you've seen, but Councillor Smage is just asking for some clarity on what offloading patients means.
Offloading patients is obviously patients coming off ambulances and making sure that we can do that in a timely manner. With the acute bed base, it's obviously a ripple effect. If we cannot flow into our acute beds, we can't flow from our assessment units, therefore we struggle to flow from the emergency department. At the moment, we're exceeding our COVID safe numbers on several occasions. So it's really important that our emergency departments are used for emergencies. At the moment, we are the one facility where people can turn up, can walk in. Most other facilities in health at the moment are by booking only. Therefore, we are seeing higher than normal attendances, and that's probably the same with my colleagues at, also on this meeting. So we have higher attendances, which does impact on how quickly we can flow through. But it's making sure we have that flow through the system so that we are offloading ambulances at an appropriate time. We can see these patients deliver the emergency care that's required and feed that through. And I can talk from a personal experience. As you know, I'm an emergency medicine consultant. I was working very late last night. And we still have a high number of attendances of patients that really are not emergency department patients. But obviously, we're trying to care for those patients as best we can.
Thank you. Councillor Smage, are you wanting to come in?
Yes, please, if that's okay, Chair. I just would like clarity. I appreciate you've been working late last night. I appreciate you've been working late last night, and you know, it's a difficult time for everybody. But I'd just like a little bit of clarity around this, because I didn't quite understand some of the points that you made. Okay, so it's perhaps me that's not fully understanding. You mentioned 2 wards that are being operated differently at Dewsbury. From what I could see. From your statement, so what would they normally be used for? You said that you'd increased daycare surgery at Dewsbury, so what sort of areas of surgery is that, as opposed to the planned surgery that's been stopped? Optimised for discharge, can you explain what that is? Because that sounds a little bit as if you're trying to move patients as quickly as possible out of the hospital. So what are you meaning by optimising for discharge? And what are P2 patients? I didn't understand that. Okay, thank you. It's probably me, but you know, thank you very much.
All fair questions. Thank you, Councillor. So the wards at Ward 12 and 14 at Dewsbury, they are the inpatients that undertake surgery at Dewsbury. So the patients that are not day cases, so they require a stay overnight or more. So those beds have been used for the medical optimised fit for discharge. Medical optimised fit for discharge terminology is slightly changing. The NHS directive is to use a term called reason to reside. And this is where patients have finished their required period of time in an acute medical bed to be delivered the care they required, and then therefore they will move back into the community setting, often to a care home or a nursing home. At the moment, there are real challenges of moving those patients the day that they are medical optimised fit for discharge, and there are slight delays, and this is where the integrated care team or discharge team are working really hard to ensure that process is as efficient as possible, because obviously when patients have finished their time requiring acute care, they need to be back into the community. No one wants to keep anybody in hospital longer than they need to be. So that's what we mean by medical optimised fit for discharge, or the new terminology, which is reason to reside. The P2s, you've got your priorities, priority 1, P2, P3, 4, so different priority scoring. So that's your P2 is your urgent patients. You've got your cancer patients, then your urgent patients. And what we're ensuring is that all our cancer and urgent patients are receiving the care that's been identified as required in a timely manner. And the presentation I submitted prior to this meeting hopefully highlights that as a trust, we're maintaining a high level to that, in line with our previous work that we can achieve this time of year. Have I covered most of the questions? Was another one I've not covered there? Sorry.
No, I think that's all right. The only other question was about increasing day case surgery. What's that involving?
Yeah, thank you very much. So day cases as a patient that can come in, have their procedure taken that day and they're discharged in that day. So we've been able to optimise the use of the Boothroyd Theatre to ensure that we are pushing through as many cases as we can, because obviously we really don't want people waiting on the need to for their surgery. So this is a patient that doesn't require an overnight stay on a ward. They can come into the unit, they can have their surgery, and they're recovered, and they're unable to go home that day.
Thanks ever so much. Thank you.
Thank you for that. Councillor Lunat.
Thank you, Chair. Just going back to something Liz has said earlier on, and asking about day surgery. How many day surgeries are we talking about here in terms of numbers and in terms of capacity? And is there a backlog being created by working this way, and how are patients being kept informed of the process? Or is it just, obviously we know what's happening, but obviously are the patients being sent letters out to keep them informed of what's going on? Planned surgeries, you mentioned at the moment you're stopping on. Is that correct? And some of the operations that you've been able to push them to Pinderfield and other places. I've heard of cases where in the last week, in the last couple of days, some of our patients from Dewsbury would have normally had the operation in Dewsbury are being told to go to Pontefract. How many are being sent to Pontefract? And obviously, how are we managing there? Because the ones I'm thinking of is that the reasons why they've got in touch with us is because they're very, very elderly and they would have had issues to get themselves to the hospital, which is very close to them. But now, obviously, having to deal with it, to go to Pontefract is another thing. But yeah, those were my questions. Thank you.
Okay, so the number of cases that can go through the day surgery unit depends on the case, because obviously it's very variable, the case length for each of those surgeries, but it's important that we're optimising that facility, on which we are, and staff have been allocated to ensure that optimisation of the services that can be run through a day case. I can't give you exact numbers because it's very variable each day to how many cases they can do, depending which procedures they are. Yes, the two sites that are providing where patients have to be admitted to surgery are both Pinderfield and Pontefract. All patients have been written to that were due to have their surgery at Dewsbury, and ensuring that they are informed that we're having to move them to the facility where they can be cared for appropriately following their surgery. So as you're right, some patients may have been moved to the Pontefract site, and I believe, and I'm informed, the Trust are supporting them with any transport needs that's required to enable that to take place.
Okay, thank you. Do you have a supplementary, Fazila?
No, thank you. Thanks for that. Thank you.
Okay, Councillor Warner.
Well, okay, sorry about that. Yeah, thank you for that. I just want to know, is this, and there's been an ongoing issue for some time regarding bed blocking, and I wondered if there has been any solution to try and, you know, avoid this happening, because I know it's been causing some concern for quite some time.
Thank you. Can I just clarify the term bed blocking? You're referring to where patients can't leave the trust when they need to leave the trust?
Correct, as in particularly most of the elderly where there hasn't been anywhere else for them to go. And so although they were ready for discharge, they haven't actually been able to be discharged because they need some looking after.
Yeah, this is the medical optimised swift discharge, or what we call the R2R patients. And this is where it's a system response that's been required to look at this. Obviously, the trust is keen to care for our patients, but once they are optimised for discharge, it's important for us so we can care for the next acute patient, for those patients to be placed. There has been challenges. There are challenges. And we're very much trying to work with our system partners. And I mentioned the appointment in Wakefield, obviously Nicola Edmondson, but it's the whole integrated system to ensure that that patients can be placed. I think that's very important. But we are reliant on our local authority colleagues to enable that process to be as efficient as possible. We're in the trust, we've looked at every bit of the pathway to make sure that we are optimising what we can do. Obviously involves like TTOs, therapy support, discharge letters, and we can optimise as best we can on that. But what we need is the places for them to go. So these patients need to be assessed and placed appropriately. That sits with our local authority colleagues, and therefore the integrated discharge package or plan or group are working together to try and improve that. And very much we would welcome our local authorities to be able to place these patients at the earliest opportunity.
Yeah, could I just further to that, really? It's just, I mean, this has been an ongoing issue for quite a long time. And I just wondered, once upon a time we had convalescent homes, and I just wondered if there's any discussion at all. I know there are constraints at the moment on practically everything, whether long term bringing back some sort of halfway houses for people who will not be ready to go home but do need some care is being considered at all.
It definitely is being considered. As you know, we have the Wakefield Intercom Care Unit placed in Wakefield, and that facility is used at the moment for that, and we're ensuring that is full to make sure those patients require that. What we call the EMI beds, which is the patients that need to be assessed further. Those beds, there is increasing looking at how to purchase further of those beds to enable, as you describe, where a patient can go that may need further assessment, or they may need an interim period of further care. That's obviously outside what the acute trust provides. And again, that's working closely with our local authority colleagues to find those places and the CCGs to make sure those places are commissioned. That's the whole system, hopefully trying to work together to make sure we have the right beds with the correct facilities so these patients can be assessed, or they can provide that interim care, which is not required within the acute trust, to ensure we can keep that maintenance of flow of those patients out, making sure they're cared for and making sure they're rehabilitated. Ideally, always back to their own home. That's always the place you want the patient to go, but then may need that interim facility. So that's very much the system having to look at this and identify that there is the correct purchasing of those beds and those facilities, so these patients can flow timely and again, always trying to get the patients home. And you can appreciate that this requires a huge amount of work from our workforce in the hospital to manage this and care for our patients. And I must call out this opportunity just to thank our workforce, because they are working well above the call of duty at the moment to deliver the care for the patients.
Andy, can I take you back to the question on bed blocking? I'm not sure whether you've actually answered that very clearly for the panel members. So if you could just have that clarity on whether bed blocking is in existence.
Well, that's the problem with the MFD. So there are beds blocked to the next acute patient because we can't move them out of the hospital in a timely manner because the facilities are not available through our local authority colleagues. So that is still there. Yes, that's what is medical optimised fit for discharge means, in the sense that we've identified them and then these patients need to move. Caring for them. One must always remember when you're talking like this, we are talking about our patients who we care for and making sure they are duly cared for. But that does exist, and that's the issue. If we could flow out the number of patients that's on the medical optimised fit for discharge list, that would create the capacity and would prevent us from having to reduce the surgical activity at Dewsbury. So very keen that working with our system partners, this happens. But the gift sits with our local authority colleagues to enable that. And the acute trust, we're making sure we're doing everything we can to make that process timely, caring for our patients, and they're available. it's a term we don't really like using, bed blocking, but that's why we use medical optimised for fifth charge, because I really wouldn't want anybody to feel that they're blocking a bed in a conversation. So it is happening. This is why we need to work as an integrated system to make sure these patients do move timely, having been truly cared for, assessed and placed in the appropriate place. Thank you,
Andy, for that clarity. Can I bring David and Suzanne in to see whether they're experiencing similar problems as the Mid Yorkshire Trust?
Yeah, so I'll answer that. So, Councillor Salmon, thank you. So yeah, yes, in short, is the answer to that. We probably have more than 2 wards full of patients who could probably be discharged, and we're working very closely with social care and community partners to try and facilitate that as quickly as we can. So it's a similar position, I suspect, to what's been experienced in Mid Yorkshire. Yeah, I think we just need to reflect that there are pressures on healthcare across the patch, not just in the acute trust, but also in social care. So we do know that our social care partners are working hard to try and find additional capacity to support those discharges. But we are in daily communication with our social care partners to facilitate that.
Thank you. Is there any further discussion or questions on the impact of COVID and on staff and hospital services that members would like to ask? Lynn?
Thank you, Chair. Yes, I would just like to raise my desire really for a consistent approach to supporting unpaid carers, whether they are escorting a person to an outpatient appointment, and it might be someone with a hidden disability as well as a condition that's obvious. Also, while someone is a patient on a ward, and also in relation to linking in virtually to video calls and telephone conference calls. And I just wondered whether lessons from COVID might perhaps result in a code of practice in relation to this. And ideally, it would be great if it could be on a West Yorkshire and Harrogate footprint, but if not, obviously we've got a clear focus on the Kirklees hospitals. Thank you.
Who would like to answer that?
So yeah, I mean, I think certainly within CHFT we've tried to establish virtual visits and video calls for patients and their relatives. I think that's been well accepted and regarded. I think where visiting hasn't been possible, it's obviously it's not a perfect solution, but it has helped substantially, I think, and we've got a team of people supporting that. I think we just need to reflect that COVID is still a real challenge for hospitals at the moment, and there is significant transmission happening, and a lot of very vulnerable patients still within our healthcare system. So, it is with some regret that we still do need to keep some restrictions on visiting. So, I fully accept that that's not perfect and it does present some challenges, but we do try and facilitate, virtual visits where we can. And in terms of moving forwards and a system-wide approach, I personally, I'm not aware of that work happening across Wyatt at the moment or the ICS, but we'd be happy to contribute to that, I'm sure.
Okay. Can I ask the impact this is having on staff, as this was one of the questions that we were asking both the trusts?
I can come in on that, Chair, give Andy a little bit of a rest, because I'm sure it'll be very similar. I think all workforces, regardless of the sector that they're in, but particularly the sector that we're both in, are seeing an enormous impact on its colleagues. And for whatever size of the organisation, we have 6,000 staff at CHFT. They have all been impacted individually and differently, but there have been some common themes that we've seen, particularly for those colleagues that are more vulnerable. So our KEVs, clinically extremely vulnerable colleagues, they've been particularly anxious, and also we're starting to see some signs of mental health issues, some trauma, particularly for those colleagues who were dealing with the COVID positive patients right at the start of the pandemic, and also for those colleagues that we redeployed to those critical areas who work in theatres and are now coping with our backlogs. So we have seen impact that is not just physical, but there's been impacts on mental health and also particularly on personal circumstances. Around about 80% of any hospital will be full of women, and women still have a disproportionate amount of care for their families. So anything that happens in schools has a knock-on effect in our workforce, and we've been trying to accommodate as much flexibility as we absolutely can have over the last 18 months. I think it's safe to say that we are facing the biggest challenges that we've faced throughout those 18 months now. That's a combination of that impact on that physical and mental health, but also unavailability due to isolation. So in our presentation, we put forward, and we know this is true for other trusts across West Yorkshire too, about 25% of our unavailability at any one time is due to household isolation. So that's either the person themselves being COVID positive or a member of their family being COVID positive, which is distinct from being contacted by the NHS app. So we are experiencing continued impact on our workforce from the pandemic. Some of that impact has also been positive from a technology and a digital point of view. David mentioned the virtual visiting, but also virtual consultations as well, which means we have been able to see some of our patients, thankfully, over the last 18 months when pathways would not have allowed us to because of the way that IPC, infection protection control, has been set up within the hospital. But I would say now is the time when we are dealing with most of the impact, and we are responding to that impact as best as we can from a colleague health and wellbeing point of view, and offering support both within the trust and with specialist teams who deal with post-traumatic stress disorder, for instance, Scrutiny and other psychological consultants to assist them with their recovery.
Thank you for that, Suzanne. Can I bring Helen Hunter in, please? Helen, you've got your hand raised.
Yeah, that's great, thank you. So there were a few things that have kind of come up in the conversation that I wanted to reflect back on, and I'm really aware as well that Stacey produced some information that's in our feedback that is about kind of hospital service provision, what we've been hearing from the public. So I don't know if there's anything in particular you'd want to ask about that, because now might be a better time than during our presentation, but just to alert you to that. I think what I wanted to reflect back was that we are perhaps hearing at the moment more negative feedback than we would expect to about hospital provision, but we are also very keenly aware that there is unprecedented demand on our hospitals at the moment, and that people's experience is going to be a bit more variable in such a challenging time when people are absolutely giving it their all. So wherever we possibly can, as a Health Watch, we're trying to make sure that feedback is going into the hospitals from us, what we are hearing, to give the opportunity and to work as constructively as possible to try to address some of the challenges that are being experienced, because we think that's a far better way of working, especially because so many of the people who are working in our hospital trusts, in our care homes, in our GP surgeries, have been giving it their absolute all for the last 18 months. And need to feel our support as much as they need to hear things that are challenging, because nobody is denying the challenges. So we just need to make sure that we're kind of being really mindful and constructive. And a really good example of that was earlier on this year when the hospitals were incredibly full of patients with COVID-19, and we had some quite negative feedback about discharge, which we were able to feed directly into both hospital trusts to support them in understanding where there might be challenges and issues at this particular time, because we realised that we can work with feedback as long as it's provided in a timely and effective way. So we tried to make the most of that opportunity. We're really aware that a lot of the pressures in the hospital are caused by the challenges in terms of flow in the system, but it does feel like that's related a lot to the unprecedented level of demand. One of the things that I would be interested to understand from the representatives from the trust, because obviously there's been some discussion about the fact that a number of people who are coming into accident and emergency are people who want to be seen urgently, but perhaps don't have the level of urgency in their presentation. I'd be interested to understand, because it would seem clear to me that there are an increased number of people with critical needs as well, what needs it is that we are sort of seeing more of, whether it's related to delays in ongoing and planned care, whether it's increasing mental health demand for mental health services, whether it's dental problems that have become really significant. So I'd be interested if there's any information related to that. And there were just two things that I wanted to provide bits of information. So I think it was Councillor Lunat asked about patients being made aware of sort of planned care challenges and what's happening in their care. I'm aware that there's a letter going out across all of the hospital trusts across West Yorkshire to anybody who has had a kind of delay in their planned treatment or care pathway, to make them aware of exactly what's happening, because there was a sense from some people who have long-term conditions and disabilities that they perhaps weren't as well informed as they should be. So I know that that's been worked on at a West Yorkshire level. And also in terms of the staff wellbeing, staff mental health stuff, there is a West Yorkshire and Harrogate support service that is available for staff from across the health and care sector, to be able to kind of access some kind of emotional support and support to help them to be kind towards other colleagues and respectful of different people's needs. So I just wanted to be clear that there's stuff that's going on to try and support some of that working. But like I say, if you want any information about the feedback that we're getting, I know that Stacey could do a little bit of an update on that, but I just want to make those points.
Thank you, Helen. Thank you for your points. Peter, you have your hand raised. Would you like to ask your question?
Thank you, Chair. Really question to both trusts, please, if I may. You've obviously been doing some quality impact assessment of the whole COVID experience, and I just wondered in the two trusts, I just wondered how common COVID was as a nosocomial infection, and in other words, people coming in didn't have it when they came in, but certainly got it while they were there. Just wondered how much of a problem that was, and alongside that, please, to really ask for what your appraisal has been of maintaining your overall level of clinical effectiveness, given that you've had your services fractured in so many places. Thank you.
Thank you for that, Peter. David, are you replying?
Yeah, I'm happy to start. So in terms of COVID acquisition in the hospital, so there's no doubt we have seen that, and we saw it particularly in the early stages of the pandemic, where testing wasn't particularly well available and there was less understanding around the control measures that needed to be put in place. But from a CHFT perspective, we've seen to date probably around about 200 people who we think have possibly acquired COVID whilst they've been in our care. There are various definitions of definite hospital acquired COVID and probable and possible. So in the probable and definite, I think probably around about 200 patients have acquired COVID. A lot of those, as I said, were in the earlier stages of the pandemic, and that does seem to have reduced. So that probably, hopefully that answers that question. I mean, clearly with a very transmissible viral respiratory infection, it's been incredibly challenging, and social distancing, ventilation, we've tried to do all of that, but nonetheless, again, some patients are asymptomatic when they arrive as well, and that's difficult to control spread from, so it is very challenging. In relation to clinical effectiveness, I mean, clearly, I'm just commenting on the points that Helen made slightly earlier as well. I mean, we do understand that, the experience that patients are getting at the moment is not where we would want it to be. They're having long waits for elective care. They're having long waits in A&E, and Andrew spoke about that eloquently before. So, how effective are we? Well, I think we've been very effective in terms of keeping up with managing the acute demands and urgent care that patients have needed, both in terms of managing COVID patients through the pandemic, and other urgent conditions that needed immediate attention. On that, from CHFT point of view, included our cancer patients, and you'll see in the graphs in our presentation that we did maintain our cancer performance. The consequences of that, unfortunately, has been an increase in waiting times for those patients who need more elective procedures, and again, you can see that in our data as well. And it is very challenging to recover that, because COVID is still a significant pressure for us. At the moment, we have over 50 patients with COVID within CHFT, and I'm sure Mid-Yorks probably have more than that. And the infection control precautions that we have to put in place to manage the spread of COVID limits our capacity as well, and it limits flow. So again, that presents a challenge to us in relation to being as efficient as we might have been in the past. You can have fewer people in outpatient clinics, for instance, because you have to still have to do social distancing. The use of PPE takes time, and therefore, and the cleaning that goes along with that takes time as well. So the flow of patients through the hospital is shorter as a result of IPC. So there's a number of things that make us potentially less efficient. I think, the other side of that is that, obviously we've been looking at how we can work more efficiently within those restrictions. So, having longer theatre lists, using technology to see patients remotely, and all of that has helped and mitigated to some degree the challenges that we've been facing. So I think it's good and bad bits around effectiveness, Peter. I don't know whether Andrew wants to comment on the Mid-Yorks experience.
Yeah, thank you, David. I think you've answered that question very thoroughly. The challenges are there. It's a different way of working. What we have to be very careful is it's a new norm. Going back to where we were is not going to be the case anymore. COVID is going to be with us for a long time. There's no doubt about that. We have 77 patients in Mid-Yorks at the moment that are COVID positive. We have a number of trust personnel that are COVID positive. So it's the impact also of trust personnel being positive, and also the isolation that they have to undertake. And some of you will be aware, obviously, since Monday, their isolation, we can go through a process to try and return them back to work. Having said that, the list of symptoms, they have to be totally asymptomatic. The list of symptoms that's come with that document is very interesting. I'm just working through that in a meeting before I joined you, is that list of symptoms could be anything. You've got the standard ones that we had before, Pyrex above 37.8, that's the temperature, that they have a new cough, or they've lost their smell or taste. But on the list is headache, fatigue, congestion, sore throat. And my real concern from that is what most viruses present with through the winter. So how are we going to maintain our workforce is a real challenge. The one that makes me laugh the most, well, it doesn't make me laugh, and probably makes me cry, I should say, is the word fatigue. I think most of our workforce has a degree of fatigue at the moment. I join that list. So we have had nosocomial spread within the trust. It would be remiss of me to come up with a number. I'd have to go back and look at that exact. Our IPC and team report that to our strategic command group twice a week. There is the outbreak meetings, very close watch, and to make sure that that all IPC measures are in place, to making sure that we are trying to treat our patients in a safe environment. We had a couple of cases there where visitors, unfortunately, have clearly brought COVID into the hospital as well. So we have to be really careful around that as well. We've maintained, as David said, we've maintained our cancer, our urgent, but there's certainly an impact on those patients that are waiting for surgery that are not cancer or urgent. And obviously we wish to recover that as quickly as possible. And hence very sad that we had to take the decision to reduce the activity at the Dewsbury site with Ward 12 and 14 becoming optimised fit for discharge patient place for them to be assessed and waiting for a placement in the community. It's very difficult. I think this is, as Suzanne described, I think this is the most challenging time of the pandemic at the moment, because we want to, whereas in the first wave, we had a very clear directive from the government, turn things off, manage your COVID patients. We can't continue to do that because that's increasing our list and list and list. We wish to deliver the care to not just our COVID patients, but all our patients. And therefore, wise ways of working. As the EPRR lead for Mid Yorks, we've undertaken a full EPRR review of the 3 waves. We're very much in the north. As far as I'm concerned, we've had 3 waves, not 2 waves as National keeps talking about when you look at the peaks. We've taken a very thorough search through the feedback and identified better ways of working so that we can maintain, and that's virtual clinics where it's possible. Some patients still need face-to-face. And it's just trying to make sure we can optimise the facilities we have with all the restrictions, IPC measures that David's described to you, that we can work as optimally as we can. And, you know, it's not for lack of effort from the staff. The staff are just trying so hard to care for our patients.
Thank you. Thank you, Chair.
Okay, thank you for that. David, would you like to come in?
Is that Dave?
Yeah, David.
Yeah, sorry, yeah. Thank you. Yeah. First of all, I'd just like to say how I appreciated Andrew's reservations about the use of the term bed blocking. I think if we can find another phrase to use, that would be very, very good. I've got 3 questions for both the trusts. First of all, just confirmation that all patients are tested for COVID prior to discharge. Secondly, I wonder whether there have been any cases of people who have been vaccinated twice against COVID actually catching COVID and being hospitalised. Thirdly, just in relation to long COVID, there's a lot of good information in your 2 reports. I just wonder whether you're coming across issues in relation to the need for social care support in relation to supporting people with long COVID. Thank you.
If I can answer that question to start with, all patients are tested before discharge. Certainly, well, going back to a care facility, they are tested before discharge. Very, very important. That's a requirement, so that is undertaken if they're going back to a care facility. Interesting on the vaccinated. So having just looked at it, we have a mixture and we report every week to the strategic group how many vaccines the patients have received. And there are patients that have been doubly vaccinated, as there are staff that have been doubly vaccinated that are currently off work. What we are seeing, though, patients that are doubly vaccinated, their symptomology is reduced, and that's the key aim of the vaccine. Unfortunately, we have got patients who have declined the vaccine, as we have a few staff that have also declined the vaccine. Those patients that have declined the vaccine, I'm afraid, are producing the more unwell patients. Okay, so there's clearly the vaccine's important, and to encourage people to undertake the vaccine, it does make a difference. With the long COVID, definitely. Some of our long COVID patients are requiring more support from the social care and ensuring that all the package that goes around a patient being discharged. It's really important we look at that. Obviously, we're still in a learning phase around long COVID, the impact this has on our patients, and sadly on some of our staff. So that's still a learning curve we're on, and learning what they require and because it's very varied, the long COVID. It's not the same for every patient. Some patients have different long-term problems compared to others. So it's understanding and making sure we are taking the opportunity to assess those patients and identify what further help they would need for them to obviously rehabilitate as best as possible to their normally daily living activities. David, are there any other comment you wish to add to that?
No, I don't think there's very much else for us to add. It's the same position as CHFT. Certainly any patients discharged to other care facilities have a PCR test before they're discharged. We have seen vaccinated and doubly vaccinated patients in hospital. And in relation to long COVID, I probably can't comment too much, but I mean, clearly we're not seeing so much long COVID in the acute trust. These are, whilst we're contributing to the management of those, it's primarily done within the community setting. So I know we're working in partnership with community partners around managing long COVID patients.
Thank you.
Thank you, David. Councillor Warner, can I bring you in with your question?
Sorry, yes, just a quick one really, which I've raised once or twice before. I just first of all want to thank you, you know, from everywhere in my heart for all the staff, for the non-stop work you're doing. But what I pick up, and as a governor too, is these word challenges and fatigue are just, I sense, you know, this is 18 months and you've got a long way to go yet. And yet the public at large is tending to feel, or many certainly, tending to think, oh, well, it's over, you know, we can go back. And I just wondered if you are feeling like you need to put, this is probably a naive question, so apologies, but an SOS out to the government that this is just not sustainable, because there'll be a point where we know all the hospitals across the country are running short of staff. And, you know, there is a danger our NHS could break. And I think many people just aren't speaking about that enough. And I just wondered what procedures you have for getting to a point where you say, this is beyond serious. You know, we're getting close to not being able to cope at all. Sorry if that sounds dramatic, but I just feel it from everyone I know involved in the NHS at the moment.
Chair, I can come in and answer that if that's okay. Councillor Warner, absolutely, and we've taken every opportunity we can to feed back through all the channels that we have just how difficult the situation we're dealing with is now. We haven't been shy also about making sure that the government is aware of the mental health impact on our colleagues. So we have several forums where we do feed this back regularly. There are forums within the NHS right up to the government for workforce, for medical colleagues, for nursing colleagues, and we frequently and regularly feedback just the state that we are dealing with, particularly the high levels of isolation that we're trying to deal with at the moment. We would love to have a stop moment and give everybody a couple of weeks off. We can't do that. So we are at CHFT, and I know Mid-Yorks are doing this exactly the same because I'm in good contact with my counterpart there. We are doing everything we can to support colleague wellbeing, and that's down to making sure they have regular breaks, they have annual leave, they have wellbeing time, because as you quite rightly say, we're probably looking at least another 18 months, so it's important that they are rested. But we do take every opportunity to make sure that those in government are aware of how our workforce are feeling.
Sorry, can I just ask, do you ever get a response?
We do get responses. I think there is definitely an acknowledgement of where people are at and where the workforce is at. I think what we would always seek is some assurance that things were going to be done about it, and we do have some regional and national hubs indeed that have been set up, particularly on the mental health side, that colleagues can go to. But that said, we won't stop making colleagues in government aware of the situation that we're in.
Thank you. Could I bring Lynn? Lynn Keedy, would you like to ask your question?
Thank you, Chair. Yes, just looking at the penultimate page of the Calderdale and Huddersfield NHS Foundation Trust presentation, where it's talking about learning from the pandemic and plan on a page. Looking at the remote patient appointment information, it actually says we want to continue to offer this improved access and ensure the benefits of digital technologies rather, are available to everyone. supporting patients who may lack skills and confidence or have limited or no access to equipment and connectivity. And I just wanted to ask what form that support is projected to take, please. And just a comment really, rather than a question, about the remote and home working, which just sits directly below the remote patient appointments on that plan on a page. I join a lot of meetings with lots of different organisations in the various roles that I deliver in the community, and I've noticed that there's a lot of people who just go from one meeting to the next, and they're often running late because the previous meeting's overrun just by a few minutes, but it means there's not much scope to have a break. And the bit that worries me really, apart from people just sitting in front of a screen all day and not having cause to get up and walk around, it is people who live alone who might be working remotely from home on a long-term basis. And I appreciate all that's in the report and all that's been said about the support for colleagues, and just want to reiterate the importance of team managers and the occupational therapy teams robustly monitoring the impact on mental health when people are working remotely on a long-term basis and not really having much contact with colleagues face to face. Thank you.
Thank you for those comments and questions. Who would like to respond back to Lynn?
So in terms of remote and home working, I guess, yeah, I fully accept there are benefits and some challenges in relation to that. And what we're trying to do is give people the option. And I fully appreciate the danger of just having a diary full of Microsoft Teams meetings and you move from one to the other without actually moving from your chair. And we need to guard against that and give people time to take a break between. And clearly the social isolation of that is important, and more so for some staff than others. But clearly we're talking about an option here, and it's probably a bit of a blended model that people will work at home part of the time, but at other times be in the acute trust. And clearly in healthcare it doesn't apply to all of our staff either. In relation to remote appointments and the use of digital technology, so I think there's a couple of things I'd say. I mean, one, we recognise that it's very challenging for some patients, but we shouldn't make assumptions. You know, some people sometimes assume that, well, the young are fine, and those who are getting on a bit struggle with digital means of communicating. That is far from the truth, actually, and many of our older population are very IT savvy. But what we need to do is to reach out to those communities, which we're trying to do, to understand what the challenges are. If they need to access healthcare in a digital format, but also to make sure that where that isn't possible at this point in time, that there are alternative ways, and that they're not disadvantaged in any way because they can't, you know, attend a virtual appointment. That we will always have an alternative for them. But it is about working with communities, I think, to try and identify, you know, where there are challenges and try and support them in how they can use the technology that's available to us. We've been doing some of that through the pandemic in terms of, you know, we talked about virtual visiting, so we have been providing equipment, trust equipment for patients to use in the hospital and needn't use their own. So if they don't have an iPad, then we can give them a laptop to use in terms of communicating with their families. And clearly we can't hand out IT equipment to the broader population, but nonetheless we might be able to provide a remote location where there's equipment that people could come in and use, for example, rather than having to come into the hospital. So, you know, this is work in progress, and I think it will develop over the next year or so as we move forwards.
Thank you.
Have a supplementary, Lynn?
No, I think I just wanted to get a feel for how it was going in terms of supporting people, you know, with equipment and connectivity. And I think the idea of a remote location, perhaps in the community, as long as it was possible to have a private consultation because of confidentiality, I think you know, it is worth pursuing, to be honest. I think it's looking at innovative ways, isn't it, to support people on a person-centred basis, basically. So thank you.
Thank you for that, Elaine. Councillor Afak-Butt, can I bring you in there?
Thank you, Chair. And first of all, may I also echo all the thanks for all the work that all our healthcare professionals have been doing throughout this time and continue to do so. My question is regarding the average age of people that are in hospital and whether that has been tracked so that we can galvanize in our own heads the average age of people that are now in hospital with sort of the severe end of symptoms. I know I appreciate you said that there are patients in hospital at the moment that are vaccinated and double jabbed as well, that don't have as many, that not very symptomatic or not as ill. For those patients there are, is there a correlation between sort of being vaccinated and age and that drop down from the first wave that we had last year to now? So has the average age dropped, and is that correct as of what we're hearing from national media at the moment?
Okay, I'll have a go, Councillor. So, you know, in all honesty, I don't think we've done a systematic analysis of the age of patients with COVID. So this is probably anecdote more than formal analysis. But what I can say is that certainly my observations are that we now have a younger cohort of patients coming into the hospital. You know, when I think about the beginning of the pandemic, and Andrew might be able to say the same here, I think the majority of patients we were seeing in the hospital were probably over 70 years of age. You know, I looked at our patient age range yesterday, and they ranged from, I think, 22 to 88. So we are seeing younger patients in the organisation at this point. I think 15 of those patients we had in yesterday were younger than 50, and I think that would have been unusual in the first part of the pandemic. So I think the vaccine is, you know, whilst we've spoken about, you know, people coming in double vaccinated, and they have, but the vaccine is still the best protection you have against COVID, and I just want to highlight that. Please get the vaccine. You know, what has happened is that the mortality rate, the number of patients dying with COVID, has reduced significantly, even if sometimes they're getting significant symptoms, so much so that they need to come into hospital. For those who've been double vaccinated, I think there's two things here. One, because we were vaccinating you know, the older population first, they've had a longer time between the completion of their primary course now to becoming infected now. I know there's a lot of debate at the moment as to whether third doses are needed to boost vaccination, but that might be having an impact. And in terms of the younger groups, then, you know, not all of those have had two vaccines. You know, some have just had one, and some have had none. So, yeah, I think it is a younger group we're seeing now than we did initially. But I couldn't give you, you know, I wouldn't write it up in a paper and publish it, if you know what I mean, at this point.
Thank you, David. Councillor Smage, can I ask?
Yes, yeah, I just want to ask a quick question. That a letter was mentioned about that's being prepared on a West Yorkshire basis for when there's delays. I think we were talking about planned surgery. I just wondered if in those discussions on that letter, whether there was going to be some mechanism for people to be able to get in touch and talk things through with people, because if your care is being delayed, there's a feeling of not being able to participate in that decision, isn't it? There's a feeling of helplessness, and there's a feeling of, well, you know, I'm getting worse, but who can I talk to? You know where I'm coming from, and people need to know who they can speak to about the problems that they're experiencing because of the delays in their planned surgery. Thank you.
If I can help there, Councillor Zaman, I'm sure the same team at CHFT, all patients on the waiting list have been contacted on a fairly regular basis to review where they are, their symptoms are best, to make sure that we are categorising them correctly. All patients that we, for example, with the Dewsbury situation, have been contacted and been spoken to ensure that explain there is a increased, maybe an increased delay if they've been transferred to another site and why. But we continue to review our waiting list and contact them to make sure they understand where they are. We understand, most importantly, have their symptoms progressed or not. And in some cases, some people remove themselves from the waiting list, so that actually they're fine, they've improved. Some people have deteriorated and their priority on the waiting list has been changed due to that. So we've undertaken a process to make sure we do regularly review the waiting list patients. David, have you got any comments on that as well?
Probably not much to add. I think we're trying to at CHFT introduce a buddy system, so it's not a clinical member of staff, but nonetheless a contact for those patients who have delayed care, who they can phone up and talk to. You know, I think, like Andrew, I'd acknowledge the importance of communication here. I haven't seen the letter that's been produced by the ICS, so I can't really comment on that. But you know, I think just recognise the importance of contacting patients who are delayed in their care.
Thank you.
Thank you. Thank you for the contribution on this item. If I can move on to requesting that the panel considers the information that's been provided to us this afternoon, and also request that we have a written update on the position of the planned surgery cancellations, maybe for the October meeting. Is that okay?
With pleasure.
Yeah? Okay. Yeah. Thank you. Thank you for attending the meeting.
Thank you.
Can move on to the next item, which is the COVID update. And we have Emily Harris that from the head of public health who will be presenting on this item.
Thank you, Councillor Zaman. So I am joined today by colleague Judith Stones from Public Protection, and Judith's going to talk through the middle part of the presentation, and then I'm going to kind of do either end. So the intention with this presentation is to give you a very brief update with regards to where we are with the COVID picture generally, although I think the information that you've just had from my acute trust colleagues has set a lot of that context for you anyway. So I'll go through that data very quickly. Judith will then come in and do a few slides on what the public protection response has been. And then unfortunately, Jane O'Donnell can't be with us this afternoon, so I'm then going to finish off the presentation by talking a little bit about the next steps as we currently think they may be, although as Andrew and David were just talking about, we're still not 100% clear on what the booster programme may look like. So that's our intention today. And the last slide I've got touches a little bit on long COVID and where we are with that. But my suggestion is that we have a broader and fuller discussion on long COVID at some point in the future, and that we bring Anita Mottram, who's our principal occupational therapist, and colleagues from the CCG who are commissioning the pathways into that. So that's how we're going to set it today. Richard, I'm assuming that you are going to drive the slides.
I think my colleague Ilan is going to do that, but yes, we can share those slides.
And then I shall do my best Chris Whitty impression and ask you to move them on, if that's okay. Yes. Thank you very much. And obviously we'll take questions at the end if that's all right, Chair.
Thank you.
It's always slightly nerve-wracking while we wait to see if this bit works.
It's just loaded now, I think.
Thank you. Okay, next slide, please.
Let's bear with that.
Okay, so a lot of this data is in the public domain, and you've become very familiar with it over the course of the pandemic. But this was just to give you a general overview of what things feel like with regards to COVID at the moment. And I think both Andrew and David were making reference to the fact that for a lot of the population, it feels like COVID is over, and it's not. So those really important messages that we have consistently given over the last 18 months now of wash your hands well and frequently with soap and water if soap and water is available, alcohol hand gel if it isn't, maintaining social distance, ventilation, and not being out and about with people if you are symptomatic remain incredibly important. The panel will remember that there was a time when Kirklees had the highest COVID rates in the country. We're currently ranked 78th out of the 149 upper tier local authorities, and our rates currently running at 292 per 100,000. So you can see from the data here that rate is significantly lower than a lot of places, Middlesbrough, Blackpool, Redcar, Cleveland, Stockton-on-Tees. This data is actually from last week, and the data gets updated weekly. We're still in a similar position in terms of the ranking, but the top 10 is looking slightly different. There's a real kind of seaside element to the top 10 at the moment. A lot of coastal towns represented. And I think what that shows us is that the virus needs people to move it. The virus is not going to move itself around. The virus will go to where people go. So where people are going on holiday and going to those coastal towns, they are moving the virus around. But I think it is worth just noting that we are currently running very close to the England average in Kirklees. And again, we had that period of time when we were running much higher than the England average, and we are now the second lowest rate in West Yorkshire. Actually, Bradford is just slightly below us. Next slide, please. Okay, so then this is just a couple of maps to look at cases by middle super output area. So a middle super output area is just a particular size of geography that we split Kirklees into for the purposes of being able to make comparisons. What you may remember from when we came to talk to you earlier in the pandemic was that we had some fairly clear places where COVID was significantly present in our population, and then some clear places where it wasn't. That's no longer the case. We have COVID evenly spread pretty much across the whole of our population. The darker the orange, the higher the rates, but there isn't anywhere in Kirklees where we don't have COVID present in our population. Next slide, please. So this is to look at vaccination uptake by age. So we can see that the blue areas have the highest uptakes, orange have the lowest uptake. But I think it is really important to note that even in those areas where uptake is not as high as we would like it to be, the uptake of the vaccine is still good. And there's something really important about how we talk in positive terms about the vaccine, and that for the vast majority of people, when they are offered the vaccine, the most common reaction is to take it. We do have some particular pockets of our population where uptake isn't as high as we would like, and that's why we are working really hard to run pop-up clinics in those particular locations, recognising that for some people where they are hesitant about taking the vaccine, making it as easy as possible for them to take the vaccine is incredibly important. Next slide, please. So this is just an opportunity for us to compare where we are in terms of the uptake of the vaccine to the other upper tier local authorities. As you'll note on this graph, the gradient is very, very flat. So there's not a great deal of difference between local authorities in terms of the vaccination uptake. And we are the blue line. And to compare us to the West Yorkshire colleagues, Wakefield are green and Bradford are orange, and the others are in between. But as I say, a very, very flat gradient. So the take-home message about the vaccination is the uptake is good, in our population. There are some areas where we could do with it being even better, and it's dead easy to get your vaccine in Kirklees. The NHS use a term of evergreen offer. So once you are eligible for the vaccine, once it's been offered to you, you are eligible to take that vaccine forever. So I don't want anybody in the population to be sitting and thinking, oh, my age cohort were eligible for the vaccine 6 weeks ago and I've missed the boat. You haven't. The vaccine is available to anybody who is eligible and wants to take it. And I think both Andrew and David in the previous item really nicely articulated that we are seeing that the vaccine is having an impact on hospitalisations. And it's so important. I can't emphasise how important it is that people take the vaccine when they are offered it. Next slide, please. And then this is just to look at overall and excess deaths that we are seeing. But again, I'm not going to dwell on this too much because I think David and Andrew have talked about hospitalisations and admissions. What we are seeing is that the age profile of hospitalisations has dropped because, as we know, the 80-plus-year-olds were the first cohort to be vaccinated. And the vaccine has significantly reduced their risk of hospitalisation. And we are seeing more hospitalisations in the younger cohort and that cohort who are either not vaccinated at all or not fully vaccinated yet. So I'm conscious that I'm talking very quickly, but I want to get through a lot, and then I want to give us the opportunity to ask questions afterwards. So if I pass over to you now, Judith, to talk about public protection and the response there.
Hi, good afternoon, Chair and Councillors. So I'm Judith Stones, I'm Acting Operational Manager in Public Protection, and I oversee the environmental health function in Public Protection. So good afternoon to you all. So I've just been asked to give you a bit of an update on where Public Protection is in relation to sort of COVID enforcement. As you may be aware, the enforcement for business restrictions during lockdowns, also subsequently in terms of the requirements on businesses came to environmental health to enforce, which we've been doing obviously since March 2020. Obviously, we've now moved into step 4 as of the 19th of July. So this is a huge change in the government's approach. You know, people talked about Freedom Day. I don't think any of us here probably feel like it was Freedom Day. I think it created a lot of concern for many of us who are here. And what we've had to do in Public Protection is to see and think about how we can continue to protect our local populations when they are going about their normal lives, whether that's going out for a meal in a restaurant or going to the shops. And our responsibility and our role in helping to keep our residents safe. So obviously we moved into step 4, which meant that there was no longer any restrictions, as the government told us all. It meant that a number of pieces of legislation were repealed, which put in place lots of legal requirements. So, for example, the requirements to wear face coverings in certain premises, but also things in hospitality premises, requirements for test and trace information. It was a legal requirement to have that. Legal requirements about distances, tables had to be in pubs, restaurants. All of those requirements have gone. So what we are left with is guidance documents that various sectors are required to comply. Well, they are expected to follow to keep their customers and their members of staff safe. So what we've been trying to do is think, how can we sort of help our local businesses, help our companies and local economy, and how can we keep people safe? So what we have been doing is we've written to all businesses in the hospitality sector, giving them advice and guidance about what they are expected to do. We've been working with the Health and Safety Executive, who are doing a project undertaking visits to manufacturing businesses in Kirklees, helping them, looking at their COVID controls, giving them advice and support. We've been doing proactive visits. We've done almost 300 since the 19th of July to hospitality businesses, supermarkets, takeaways and pubs, going to explain to them, you know, the restrictions have ended, but there are still things you need to do to keep yourself and your staff and your customers safe. and obviously proactive visits to gyms and soft play and so on. We've also been heavily involved with advising people who are wanting to stage events through the Safety Advisory Group, and I'll talk about that in the next slide shortly. So we've been doing quite a lot of proactive work, and we will be continuing to do that proactive work, and really pushing the key messages of basic hygiene and hand washing, enhanced cleaning in businesses, increased ventilation. But some of this is quite difficult because when the whole social distancing is no longer required and face coverings isn't required, it can be quite a challenging message to try and get across to business. There is this feeling that it is all over. So we're sort of collating how we feel the businesses are doing with that guidance, and we will look at our next steps once we have kind of done all of that work. The other really crucial sort of public health work we are doing is we do door knocking to visit every single positive COVID-19 case in Kirklees. And there's two reasons for that. One is to make sure they are self-isolating, but second, and probably more importantly, we're visiting those people and offering help and support, finding out, do they need shopping? Do they need, prescriptions picking up? Giving them the details and the numbers they need to be able to get that help and support. And obviously with the Delta variant, I think there's approximately 250 to 300 door knocking visits being done per day by public protection employees. And it's really crucial work, and it's being really, really well received. With the changes this week to the contacts, because we also were door knocking all the contacts of positive cases as well to ensure they were self-isolating. Obviously, with the changes this week to the requirements for contacts and self-isolating, we are expecting to see a bit of a decrease in the numbers that we need to visit, but this is obviously early days and we'll need to just sort of keep that under review. And then the other sort of public health work that we're doing is we're very involved with incident management team in relation to any variants of concern, but also visiting businesses that have had outbreaks. We're monitoring with our public health colleagues if there's any uptick in numbers of positive cases in businesses and employers, and then we visit them and we look at their risk assessment and their controls, and we offer advice and guidance. Could I have the next slide, please? So I touched on this just very briefly. There is a safety advisory group in the council that's been going for a long time, and we, along with infection and prevention control colleagues, sit on that advisory group, and people who are wanting to put on events or something like that, they can get a slot on that advisory group. We'll review their risk assessments in relation to COVID, but we also look, because we're environmental health, we also look at any noise impacts, any other sort of amenity problems with the proposal. But we have a real strong focus as well on COVID secure events and making sure that people are following what the guidance is for events, looking at their risk assessments. But then we've actually followed that up actually during events to check, basically ensure that it's safe, offer advice, but also challenge where there are things not being followed. And next slide, please. So obviously without the sort of same legal backing that we had under the STEPS regulations, another piece of legislation, we have to consider what enforcement action we can take or is appropriate to take. So we are doing a lot of proactive work, and we are sort of rag rating these visits, and obviously any that flag red we will look at again, but we are heavily spending our time educating, supporting and encouraging people to have these controls in place, because for most businesses it's also in their interest, because if they have members of staff who test positive, then obviously they'll have to self-isolate, and that has huge impact. So what we're going to take into account if we're considering enforcement action is, have we had complaints about a business? Have there been outbreaks linked to the business? Have we been and then offered advice and they've just failed to take that up? What are the risks to the members of the public or employees? You know, there are a lot of people in vulnerable groups that might go to these premises, etc. And have they done their risk assessment. So under the Health and Safety at Work, etc. Act and associated regulations, all businesses are required to have a COVID-19 risk assessment, and where there's 5 or more employees, it must be written down. So we'd be checking that they're complying with those legal requirements. The tools we have available for enforcement are under the Health and Safety at Work Act. We could serve an improvement notice, for example, if they haven't got a risk assessment, we could require them to to develop one and put it in place. There are prohibition powers under the Health and Safety at Work Act, but the steer that we have from the Health and Safety Executive is that because COVID-19 doesn't have severe consequences for the majority of the population, the use of prohibition powers would not be deemed to be appropriate. So the other option we do have is under the Health Protection Coronavirus Restrictions England number 3 regulations, which gave local authorities powers to prohibit premises or prohibit events or activities. And these regulations have remained and will remain till the 27th of September, and there are discussions that these may continue. So that's the sort of current picture from the enforcement point of view, and I'll hand back to Emily, and obviously we're happy to answer any questions at the end. Thank you.
Thank you ever so much, Judith. Next slide, please. So I'm going to move on now in the presentation to start to talk about the COVID booster vaccination programme. And I really hoped that by the time I came to this scrutiny panel, I would be able to say to you, and we've got a really clear plan in place and we know exactly who is going to be eligible for the booster vaccination. I don't have that clarity and I don't expect to have that clarity now for a few weeks. So the decision as to who receives the booster vaccination, if they receive a booster vaccination, sits with the JCVI, and that decision will be made on the basis of clinical trials and understanding the impact of boosters on those people who are most vulnerable to serious COVID-19 ahead of the winter months. And clearly the absolute ideal would be that COVID booster programme was delivered alongside the flu vaccination programme. We're still not 100% clear either on how that is going to work, but working very hard to get ourselves to a point of clarity. Obviously, the COVID vaccination programme is commissioned through a different route than the flu vaccination programme is. So there's some crossing of T's and dotting of I's that need to be done in the background before we can be really clear on what that programme will look like. But the most important thing to say is when you are offered your flu vaccine, please take your flu vaccine. If you are offered a vaccine for COVID, that will be on the basis of really good, robust scientific data that tells us that that is a thing that people feel is necessary for you as an individual. So please take it when it is offered to you. Next slide, please. So this is what we thought the eligibility criteria for the COVID-19 booster programme was going to look like, and it may still look like this, but it's not quite as clear cut as I said, as I hoped it would have been by the time I came to talk to you today. So the most likely first cohort to be offered the COVID-19 vaccine are detailed here, and then stage 2 as well. But I don't want to dwell on it too much because it's not quite set in stone yet. So next slide, please. So I just wanted to take the opportunity to talk a little bit more about flu. We've seen relatively low levels of flu over the last 18 months, because if you think about the restrictions that we've had in place and the extra care that people have been taking in order to avoid COVID-19, of the hand washing, use of face coverings, social distancing, additional ventilation, staying away from people if you're not very well, that has clearly had an impact on the level of flu circulating. So there's all sorts of things that we have learned about how we look after each other better because of the COVID pandemic. So I would actively encourage people to continue to do those things, because not only have they had the impact on COVID-19, they've had the impact on influenza, and we've also seen much lower levels of things like norovirus and diarrhea and vomiting over the last 18 months, because who knew that washing your hands would have such a significant impact on a disease like DNV. Next slide, please. So this is just to make the panel aware of some additional activity that we've seen in the system with regards to paediatric RSV. So we usually expect to see paediatric RSV in the winter months. So it's a respiratory virus that affects particularly young children. And we've seen a higher level of paediatric RSV for this time of year than we would previous. Pediatricians are telling me that they think there's a couple of reasons for this. And didn't because they were isolating and weren't mixing with people. So we've got that cohort of children having it at the same time as the cohort of children who would normally be getting RSV. And they think that it's been brought forward slightly because as people have started to mix more, again, a little bit like I was saying earlier, the virus needs people to move it around. So you've got babies and small children who haven't seen granny or auntie or whoever over the period of the pandemic. They are being taken to meet more people than they've met previously. People are hugging and kissing them because they're babies and we like hugging and kissing babies. And that is partly contributing to a slightly higher rate of this pediatric RSV circulating in the population. Actually, since we put these slides together, we're seeing a bit of a levelling off, and there's some work being done at a West Yorkshire and Harrogate level as well to increase people's awareness of paediatric RSV and to support parents to know what to do if they are worried about their child. Next slide, please. So I said at the beginning that we would finish the presentation today just by giving a really brief update on long COVID, and I know David and Andrew talked about it a little bit in their presentation as well. So there has been a short report on long COVID that was delivered by the Office for National Statistics in July. There is no universally agreed definition of long COVID, and I think it's really important that we recognise that it's not about saying you have a specific thing. It's a broad range of symptoms. It affects different people in different ways, so things like fatigue, muscle pain, difficulty concentrating, it will be very different for different people. So it's something that we need to be really, really mindful of. And it's part of why that narrative of looking after yourself and avoiding catching COVID as much as you possibly can is incredibly important. So we know that the vaccine is having a really significant impact on the level of hospitalizations and deaths, and is doing what we expected the vaccine to do. The vaccine, however, was never designed to stop you from getting COVID. It was intended that it would stop you from becoming very, very unwell. So I think we need to be very cognizant of long COVID. We need to be really getting onto the front foot so that we've got an offer that we can make to our population if they experience those symptoms of long COVID over a protracted period of time. But what I would suggest to the panel is that Anita Mottram, the principal occupational therapist, is invited along with her colleague Alison from the CCG to talk about the work that they've been doing to set the clinics up and to make sure that people are having their medical and non-medical needs met with regards to long COVID. Next slide, please, which I think is the last one. Okay, so this is just to give you a little bit of a context of what for long COVID. So there's money being spent on diagnostics, on rehabilitation, on assessment clinics, really trying hard to coordinate people's care. So if they need to see more than one specialist, that's being done in a coordinated way that makes sense to them. but really we are still learning about long COVID. We're learning about who it's affecting, we're learning about how it's affecting them, how long it's affecting them for, and that will impact and inform how we develop services going forward. And that's the last slide. You're on mute, Councillor Zaman.
Sorry. Thank you, Emily and Judith, for that comprehensive presentation. If we can move on to the panel, if there are any questions to ask Emily and Judith. Peter, can I bring you in first?
You're on mute, Peter, but your questions are always good and worth waiting for. So
I'm sorry to let you down, Emily.
It's okay. It's nice to see you.
And you too. Just by way of these hotspots, which keep being mentioned in the examiner, and you've referred to it being pretty much an equivalence now right across Kirklees. Is that really the case, or is there a commonality in certain parts of the borough? Are there certain common features that that are causing people either not to be vaccinated or to be not being aware of social distancing, or anything that would influence the pathology that you can say, well, if we could deal with this, it would be helpful?
So what the data shows us, Peter, is that it is very evenly spread across Kirklees at the moment. And when we look at every week at the wards that are in the top 10 of numbers of cases, and it bounces around, it moves. So if we think back to kind of 6-8 months ago, there was a set of wards who were very consistently in the top 10. That is not the case anymore, and we see it. You're as likely to be in the top 10 for numbers of cases if you are a white, affluent, very privileged ward, and if you're not. There are clearly things that make it easier for certain people to follow the guidance than others. There are people like me who are able to work from home, who have a space to work from home, who are able to choose to go shopping at times when they know that the supermarkets will be quieter, and to really limit their social contacts. And there are people for whom that is a much harder choice to make. But there isn't a particular ward in Kirklees where we can say it is consistently worse there, and therefore you need to be focusing our resources. We know that if you live in a particularly densely populated area, it's harder to socially distance. We know that if you live in a house of multiple occupation or a multi-generational household, it's much harder to socially distance. So there are certainly people for whom it is easier to follow the guidelines, but this is a very, very infectious disease, particularly the Delta variant. So it's spreading throughout the population. In terms of the uptake of the vaccine, there are particular pockets in central Huddersfield and in North Kirklees where the uptake of the vaccine is lower than we would like it to be. So we're doing lots of very proactive work in those communities to take the vaccine as close to those populations as we can, and to answer their questions around vaccine hesitancy and concerns that they might have about taking the vaccine. And the emphasis on making it as easy as we possibly can for them to take the vaccine.
Thank you. Could I also ask, Emily, with regards to PPE, are you in any way at variance with the government's policy on this? Because they seem to say you can please yourself, whereas most people would subscribe to the idea that at least a medical grade mask makes a difference.
So my personal view is that when I am in a space with people who I don't live with, I will wear a face covering because it is the kind thing to do. And I think we really have to keep an emphasis on kindness and looking after each other. And there are people out there who are incredibly anxious about COVID. And there is evidence that the use of a face covering makes a makes a difference. And I can't remember if I've shared with the panel before the Swiss cheese diagram. If I haven't, I'll send it to Richard and ask him to circulate it, because what we need to think about is that none of these things in isolation are going to make 100% of the difference, but all of these things when held together will make the difference. And the Swiss cheese diagram is essentially saying, you know, if you've got slices of Swiss cheese that have got different holes in, you need to line them up so that the virus doesn't get through. So wearing a face covering, washing your hands, maintaining social distance, and doing all of those things that keep yourself and others safe remain incredibly important.
Thank you.
But
Thank
kindness. And if you remember, do you remember last time or the time before I came to talk to you, we used the line from Jurassic Park of just because you can doesn't mean you should?
Yes.
I'm still in that space.
Thank you. Thank you very much.
Thank you, Emily and Peter. Could I request Dave Rigby to answer his question, please?
Okay, thanks. Yeah, I've got a couple of questions on the public protection slides and one on the long COVID plan slide. On public protection, I just wondered the extent to which people who are self-isolating are qualifying for financial help whilst they're doing that. And the second question is, I assume you're monitoring any larger scale outbreaks of infection that take place. Is there then some feedback to similar kinds of locations to sort of say, this is what's happened so far in locations X, Y, and Z. You need to do this if you want to try and prevent this happening in terms of your location?
Yeah, so I'm afraid on the first question in relation to financial help, I wouldn't have any information on that specifically. I'm sure I could go away and get that and provide that back to everybody with pleasure. The second issue in relation to events and so on, I mean, this is one of the test and trace questions with any positive. Have you been, you know, where have you been? And one of the things is about larger scale events, Emily, I think is something that's covered now, isn't it? So that will then pull through that there has been a lot of people who have subsequently tested positive. In terms of us talking about other problems, we will talk generally in relation to other problems or other circumstances we've come across. And the one thing with COVID is our knowledge and our advice has built up over this significant period of time. So we will always apply what we've learnt from other situations in the advice and so on. But the government has got some very detailed guidance on things like events or outdoor performances or the performing arts, and we will obviously guide people towards that, and the advice that we give will be based on that. But where we have had specific issues or problems, then obviously we do share that with those people, but obviously without naming names or where that was.
So just in response to your question, Dave, about the support payments, I've popped a link into the chat. So if you follow that through, that will tell you exactly what the payment options are and who's eligible for that level of support. And I've also put the picture of the Swiss cheese diagram in because I really like it.
Okay, thank you. And just in relation to the long COVID slide, the £100 million you refer to, is any of that available to be invested in social care services to support people with long COVID?
I think so, yes. But to what extent and what proportion of it is, I don't know. And then that's the detail that I would suggest it's useful for the panel to ask Anita to attend for, because she's got the detail on that one. So that's a really flaky answer, I'm sorry.
Okay, thank you anyway.
Thank you. Can I ask Councillor Fazin that?
Thank you. Thanks for that, Emily and Judith. Just in regards, and some of the questions I wanted to ask you've answered in the report that you've given, but when you've talked about changing from rules to going to just government guidance, and the uptake from local businesses to actually follow those guidance, how supportive are you finding some of these businesses? I'm assuming that some are okay and happy to support, and some are not as easily persuaded, and guidance is guidance, it's not the rule, so it doesn't matter as much. Whereas obviously from a council point of view and a public health point of view, we'd prefer them to follow that guidance, to the dot kind of thing. How persuasive are we, and are there future plans or projects in place to kind of work with local groups or businesses to get that uptake of guidance managed better? Thanks.
Yeah, I mean, I think what we've found throughout, as we always do in our, we are regulators in public protection in the main. I think what we generally always find is the vast majority are doing the right thing and are doing their best. There are always a much smaller percentage of the businesses that aren't following the guidance. The difficulty we have now is obviously we don't necessarily have the legal provisions to back us up and to insist upon it. So it's still quite early days, is what I would say. I think generally most businesses are following the guidance and are doing their best, but obviously that's hampered to some extent by the public not always wanting to do that and follow the rules that they're trying to put in place. So I think the simple answer is we need to see how that plays out. But so far, I think a lot of businesses are doing an incredibly good job to try and to comply with that guidance and have got risk assessments. And my own personal experience has been that a lot of businesses are kind of continuing with a lot of what they already had in place. For example, just because restaurants can have all their chairs right up against each other now, I'm finding that a lot of them aren't. They're still doing one-way systems, they've still got sanitisers, they're still asking people to check in with test and trace, and I think that's really, really positive. And it's something we are looking at. And what we're also looking at is whether there might be some other sort of schemes we can help and projects we can help to support those businesses with some sort of, I don't know, accreditation scheme or something like that, for businesses that are doing really, really well at trying to follow the guidance, follow the rules. And well, they're not rules anymore. This is part of the problem, isn't it? But to keep themselves and their staff safe. And this is what we're really trying to push with these businesses. Look, you might not agree with any of the rules that have been in place, but if all your staff get COVID-19, they will not be able to come to work, and you may not be able to open your business. So we're trying to use our powers of persuasion, as it were. And generally, I think the response has been quite positive. And a lot of businesses want to stay open. They don't want a return to lockdowns and restrictions. And I think they see that it's important they keep going.
Thank you, Judith. Councillor Rappart, would you like to ask your question?
Hi, my question is just with regards to something that Emily had said about some of the infection rates and where they are. And I do know that I'd read that there had been more infection rates. I think not infection rates. Sorry, the lack of vaccination in Ravensthorpe. I think that was one place. I don't know if that has changed. And I'm just citing that as an example. That where there is a low uptake of the vaccinations. Is there anything that sort of we as the elected representatives on the ground can kind of do? Are there any plans to kind of engage with us to be able to kind of reach out? I know some of us are quite active on social media. We do have the kind of community groups, and we are part of that, and we do sort of let them know about what's going on, the latest in our areas. But I think if some of the elected representatives could have a role in doing that, a bit more of a strategic role, to be able to get some ideas about how to engage with some of the community leaders, some of the community elders that may be able to put that information across. I'm thinking of community groups, voluntary groups, I'm thinking of women's groups, I'm thinking of mosques, churches, whatever, that could help. And it's the people on the ground that will be able to help on that. And I think there is something to kind of do around that. I don't know if you've had to think about that and how to engage with elected representatives on the ground.
Okay, thank you for your question. We've done quite a lot of work to deliver pop-ups in particular communities where the uptake has been lower than we would have liked it to be. I think there are a few things that elected members can do to support us, and you've described a lot of them already. Amplify what we send out through social media. It's a very technical comms term that I learned last week. It just means forwarding stuff on. But if you can amplify our messages within your communities, particularly in those communities that we know that we don't have particularly good reach into. We know that there are lots of communities where Facebook, Twitter really doesn't have the penetration that we would like it to be, but there are myriad WhatsApp groups. So if you can take the messages that we're giving about the importance of the vaccination and where you can take the vaccination and put it into that WhatsApp forum, that's an incredibly useful thing for us, for you to do. I think it's really important that we talk about the vaccine in positive terms. So there are no communities in Kirklees where the uptake of the vaccine is bad. The uptake of the vaccine is generally good across the whole of our population, but there are specific pockets of our population where the uptake is not as high as we would like it to be, and Ravensthorpe is one of those, and that's why a lot of the pop-up clinics are being taken into those communities, so that people's reason for not taking the vaccine isn't, well, I couldn't get to one, I couldn't travel to one, because we've taken it to them. But I think talking about the vaccine in positive terms, being really clear about what you've learned in this scrutiny panel today, that our acute trust colleagues are telling us that the vaccine is breaking the chain of that relationship between contracting COVID-19 and being admitted to hospital. And really helping us to amplify those messages into your communities would be incredibly helpful.
Just one final question, if I just may, very quick. Would it be possible if you could possibly send us a kind of the latest in terms of which areas have got relatively low, like a league table or something, as to where that stands, just so that, you know, I'm just thinking of the elected colleagues that are on here. Well, we could have a look at that and maybe speak to our colleagues and say, actually, we need to do a little bit more work. If the penetration of the vaccine takeaway is good in different areas, it's about how to then have that parity between different areas and how we can do it.
So what I'll do is I will ask my colleague Matthew, who is the project manager for the vaccination programme, because the vaccination programme is being run through the NHS. So we have a significant role in supporting that, but we're not running the vaccination programme. So I'll get the person who owns the data to share the data, because that's always a sensible thing to do. But I'll ask Matt to share that with Richard, and then that can be circulated to the panel members.
Thank you for that, Emily. Lynn Keedy, would you like to ask your question?
Thank you, Chair. Just a couple of points, please. With regard to the Kirklees Council teams themselves resuming public meetings and events, and in the interest of consistency across the board, I was just wondering to whom teams will be looking for guidance about when it's appropriate to resume and how to go about doing that safely, please. And my other point relates to long COVID. And I mentioned to my colleagues earlier when we had our pre-meeting that reading through the information, it just suddenly struck me that I wouldn't want people who've had COVID, who afterwards develop symptoms, to just presume that it's long COVID and think, well, I'll see how it goes, and that we encourage people always to get some medical advice about any symptoms in that regard. So that was all I wanted to say. Thank you.
Okay, so I'll take the first question about Kirklees Council staff and resuming activities. There are some members, obviously our frontline staff have been working throughout the pandemic and continue to do so. Those of us who have been working from home for quite an extended period of time now, we are making very, very thoughtful decisions about how and when we bring people back into the workplace. For some of our jobs, it's very clear that we can spend a good proportion of our time working from home, and where that can continue, it will do, certainly for the next few months, and the decisions are being taken kind of into the autumn as to how people will return to the office environment. The emphasis that I am taking with my team, with the public health team, is that we will come together when it is necessary for us to come together for collaboration, and when we will get better outcomes from the meetings by being together. But where we can work from home, we will continue to do that. And then in relation to your second question about long COVID, I think when Anita comes to talk to you, she will be able to talk very specifically about the pathways and how people will get that level of support. It's really, really important that that's done initially on a clinical basis, because what we don't want to do is make assumptions of, oh, it's long COVID, and not do the appropriate investigations that find that it may be something else. So it needs to start from a clinical point of view, and then discount anything else, and then where it is, when we are confident that it is long COVID, that is the area that people need support, then some people will need that support to be very clinical, and some people will need that support to be about gaining confidence and being outside and meeting with other people. So it will be much more of a social response. But I think Anita will talk really passionately about that when she comes to talk to you.
Thank you, Emily. May I just ask one further point about my first question? Yes. Thank you for the update about colleagues resuming contact. What I was thinking about more was the meetings, like, for example, the scrutiny panels, the Mental Health Partnership Board, the Suicide Prevention Action Group, those kind of meetings where colleagues attend from the council, but also community partners. Okay. And I'm just wondering where the lead about resuming those will come from. Will it be individual teams that decide, or will it be a council directive, please? So
that piece of work, Lynn, is being led by our ET colleagues, so Jackie Gedman and the strategic directors, and Joanne Bartholomew is leading on that piece of work for that senior management team. So they are working on that as we speak. I expect that we will get an update from the chief exec in the next week or so that will give a really clear direction of travel. So that will be the corporate stance, and then it's about people doing what is right for them as well. So certain people will feel much more comfortable coming back into shared office spaces more quickly than others will. So I think we will move into a period of time of a bit of a blended approach, and it's going to take a bit of time to understand how that's going to work. If you think back to what the start of the pandemic and how clunky we were on using Teams, and how, you know, we'd forget to unmute ourselves, or we'd forget to turn our cameras on or off, or, you know, we've become much slicker at that over the course of the pandemic. And it's going to be a little bit like that, but at the other end, where we learn how to do a Teams meeting when some of us are all sitting in the same room together and some people are still sat at home in their spare room. So a blended approach, I think, is how we're going to move. But ET are working on a recovery position for the council, so I would expect to hear from them relatively soon.
Thank you, Emily. It's just reassuring to know that colleagues throughout the council will have a point of reference, really, and someone to go to for guidance. Thank you very much.
You're welcome.
Thank you, Emily. Can I now bring Leslie Warmley in, Councillor?
Yes, hi, thanks. I'm just following on really from earlier questions, which is, you know, we must all of us must be experiencing people who are saying to us, it's over. You know, you can go to the pub and I'm wearing my mask, and they're going, it's over, why are you wearing it? And I just wondered if Kirklees needed to do some comms. It's not about scaring people, but, you know, we were told earlier it's going to be around for at least 18 months, probably longer, who knows, that actually the government have stopped taking the lead on this now. So my question is it up to the council to up the game a bit more?
So there are still regular communications from the council and from Rachel Spencer-Henschel as the Director of Public Health specifically. And what we are trying to do, when Judith was talking about the way that public protection are are discharging their duties of educate, support and encourage. We're very much trying to stay along those lines, that we can't make people do these things now, but what we're trying to do is encourage people to do the thing that is kind. And a lot of people are still behaving in ways that are kind and considerate of other people. There is a limit to what we can do as a local authority without regulations to fall back on, because we can't make people do this. So Rachel, as the Director of Public Health, does still have a role in reminding the population of hands, face, space, ventilation, regular testing, isolating if you're positive, and you will continue to see those comms coming over the coming months. But the main message here is just be kind to each other and do the right thing, look after each other. And I've lost count of the number of times I've told people to wash their hands now, but keep doing it.
Yeah, fine, I get that. And obviously we see all the comms, et cetera, that come through. I just wondered whether, as councillors, for example, all of us on whatever post we're doing should be posting some agreed, some of the things you've just said. I mean, you know, because when you talk about doing it with other people, say, well, you don't want to scare people. But, you know, on my own post, I can put things that more updates that I've learned in this meeting. But should I be putting that in the Slough community group, for example, where you're open to being, you know, starting the whole debate on vaccinations and blah blah blah? You know, it's a tricky balance.
It's a really tricky balance, because you've got to hold it in the whole of the context of all of the other work that you want to and need to do with your communities as well, haven't you? So it's not my place to tell you how to kind of discharge your duties as councillors, but COVID is still with us. We are still seeing higher rates of COVID in our communities than we would like. The uptake of the vaccination has been good, but it could be better. And if you haven't taken the vaccine yet, and you are eligible for the vaccine, it is still available to you. And please continue to take regular testing. And if you're positive, take self-isolation seriously, because that's how we break the chain of infection. And if you as councillors wish to amplify those messages in the community groups that you have access to, then I think that is the right thing to do from a public health point of view.
Thank you for that, Emily.
I very confidently told Richard it would be a quick item and that we wouldn't take long. I was wrong.
It's absolutely fine. It was all very good and important. But thank you, Emily, for attending, and Judith. If we can note the comments and the discussion, and I don't have any sort of further recommendations to put to you, but you know, it's an ongoing issue, and we do have this as a regular item. So,
well, I await my invitation to come back next time.
Thank you, and well, thank you both for attending. And we can move on to the next item, which was the update from Health Watch, Kirklees Health Watch. Unfortunately, both Stacey and Helen Hunter, Stacey Appleyard and Helen Hunter, need to leave the meeting for 4 o'clock, and we've just gone over 4 o'clock on this item. So if we can defer that to the next meeting, if the panel are okay with that, we invite them for the October meeting.
Okay with that.
Okay. So we move on to the next item, which is the work programme, and if I can bring Richard in to take us through that. Sorry, something.
Yeah. Thank you, Councillor Zaman. Right, so I thought probably the good starting point would be the agenda plan, which is obviously attached to the back of the work programme. And obviously, in light now that we're deferring the Health Watch item to the October meeting, the proposal, we've already got 3 items on that agenda. We've got the update on winter planning, we've got the Kirklees Care Homes programme board update, and we've got the health and wellbeing strategy. So the proposal would be to move one of those items back to the November so we can make room for the Health Watch. And my suggestion would be the Kirklees Care Homes Programme Board update. So obviously I would need to seek approval from the panel whether they're happy to actually do that. Just to confirm, the rationale behind that is obviously update winter planning, that we usually have it around October because it's quite a crucial period for NHS, and that's the time that they'll be ready to present their sort of plans, and obviously we can go through lessons learned from the previous winter. So I think it will be helpful to keep that for that October meeting. The health and wellbeing strategy is has been asked. There's been a request to actually share that with the panel. And that is time critical. That is something that will be going to the board. I think probably I think it's in November actually, and they are seeking sort of the views and comments from the panel. So I think it would be helpful, obviously, to keep that in so they have an opportunity to take on board the panel's comments. The Kirklees Care Homes Programme Board update isn't as time critical, and in fact probably. With the proposal to cover the community care services in November, those two items actually probably go quite well together because there is links between the works that have been done through the Care Homes Programme Board, particularly with a focus obviously on the impact the pandemic's having on care homes and the work of community care services. So it's really over to the panels whether that proposal they're happy with.
Yes. Yes.
Yes.
Yes.
I think Vazilla wanted to come in, Councillor Zaman.
Yeah, I'm not sure whether she's got.
Yeah, sorry, I couldn't hear you properly. I was just going to say I agree with what Richard has said. Before Richard has mentioned it, I was going to ask to move item 2 in the October plan to November. But yeah, I'm happy to move that if somebody would second it.
Do we have a seconder? Councillor Bilama would like to second that. So that's moved. So
okay, that's great. That's great. The other thing then, before we go on to the main work programme itself, was to get the views of members in relation to the COVID-19 updates that we've been getting. Obviously, they have been a regular update that's featured at pretty well every meeting, certainly last year and so far this year. It is important. I know members do want to get a real feel for what's happening in relation to the pandemic, but obviously it does take up quite a chunk of the time of the meeting, which obviously puts pressure on obviously covering some of those other items. So I suppose the question to the panel would be whether they feel there is still value to include the COVID-19 update as a regular standing item, or whether they'd be happy for us to seek written updates which we can circulate outside of the meetings to panel members, and if there are any specific issues that members feel particularly strong about that they feel maybe it ought to come to the panel, obviously we could arrange to do that. So the proposal will be to drop the COVID-19 update as a regular standing item, monitor it through written updates, and then bring back to the panel if there are any particular emerging issues that the panel feels strongly enough about that they feel it warrants a discussion at a meeting.
I'm happy with that, Richard. We have had that discussion, but it's whether panel members feel that's the best way forward, because it's like you say, it does take a chunk of our time, and the evidence is there today. Leslie, you've got your hand raised.
I'm sorry to be the awkward squad, but I actually don't agree. I think it's really important. I think it's changing all the time, and I don't understand why we can't just have, whilst we're in this time of COVID, a slightly longer meeting. Is there any reason why we can't say, well, okay, there's an extra half hour going to be added to each of our meetings whilst COVID's still around?
Do you want me to respond to that, Richard?
Yes, you can do.
Whilst I agree there is no specific time limit on having the meetings, but Leslie, when we start at 1:30 and we're expecting members, to attend a meeting that's 2.5 hours long. You know, it's more about the time span and the sort of capacity to sit on a virtual meeting for 2.5 hours. And you're saying that take it much longer. You know, we either schedule a break in the meeting and then go forward, or you know, we sort of continue as we are. What do panel members think?
I think it could, Chair, with respect to Emily and her colleagues, it could be a little bit more compressed if it is to remain, because there's an assumption made that none of us can read, whereas we've all read the data before we come here.
Exactly.
And if there were a compromise, you know, if it is necessary for Leslie to, you know, to have what the members to be able to ask pertinent questions, but to just ask, if kindly, you know, please don't tell us what we've already read.
Yeah.
And I don't mean that in a destructive way at all, because the information is very valuable.
Yeah, I think 10 minutes of questions, I would go out, you know, if we could have some questions on, you know, the update we've got, I'd be happy with that.
Yeah, 10-minute rule, Bill.
Councillor Armour.
Yes, thank you. I'm making really the same point. We councillors, certainly we get regular updates, a couple of emails a week at least. So we are kept abreast of the broad picture with COVID. And I don't think we need to be adding time to these meetings. I really, really don't think we ought to be lengthening these meetings. I think they're long enough, thank you very much. So I'd be happy to see this dropped as a regular item, assuming that, or if you like, in the case that we continue to receive regular updates as councillors. I think we are kept abreast of the situation.
Thank you. David Rigby?
Yeah, thanks. Just wondered whether, as an alternative, obviously today's report was reports from both trusts were pretty lengthy. Whether we could consider something like an exceptions report, where we just pick up on those issues that have new or have changed or have become more serious than they were, rather than trying to cover everything across the board like we did today.
Thank you. Any further comments? Councillor Arafat, Councillor Lunat.
Yeah, so just to be clear, I don't know what we're deciding with this, because I'm not as keen on, although it's a very important issue. I've got another meeting. I've got half an hour break, and I've got another meeting to go to. I wouldn't be able to continue another half an hour, even though it sounds okay, stay another half an hour, but I've got another equally as important meeting that I need to attend, and I wouldn't be able to do that. In regards to getting a written report, I'm happy to have a written report as an agenda item that we will acknowledge and ask questions on the specific bits that we need to pick up. And if members are happy with that, we could possibly look at that. And I think somebody's already mentioned that. Thank you.
Thank you.
That makes a lot of sense, I think. Thanks.
Thank you. I'd agree with that. Richard?
Yeah, I mean, what I can do is I can speak to Emily, explain the position in terms of the panel, and what, as you say, I mean, I'm quite happy. I'm sure they'd be happy to provide a regular written update. I mean, I quite like the idea of maybe having that kind of exceptions report, highlighting maybe those issues that have emerged that maybe that only just started to happen, or there might be issues that they feel that need to be escalated to the panel, and maybe just see, even if it's just like a 10 or 15-minute slot, just see that if necessary, they're available in the event that there are any specific questions or queries that panel members want to highlight. And that's kind of like, I suppose, it is a compromise, isn't it? It's what we're trying to do is obviously manage the time as efficiently and effectively as we can, and that might sort of hopefully satisfy Leslie in terms of having that opportunity to have that discussion, but at the same time, obviously, ease some of that pressure that we've got in terms of the timescales for the meetings that we hold. So if members are happy with that, I can maybe just work with public health, and then I can email you all separately, or email you outside of the meeting in terms of the proposal and how we can sort of take forward the COVID-19 updates.
Mm-hmm.
Okay. Right. So on the basis of what we've just discussed then, so just to confirm, for October meeting, then we will have the update on winter planning, and that will be a whole system update. So that will include representation from all our main organisations, both in health and social care in Kirklees. The Care Homes Programme Board update, we are proposing to push back to the November meeting, which will mean then we will have the health and wellbeing strategy as our other item, and of course the Health Watch item, which we would have covered today, will also be included as well. November, that therefore now has 2 items on it, which is obviously the community care services and the Care Homes Programme update. In light of what we've just discussed, do members feel that those 2 items, bearing in mind that we will have that short written update, as we will with all of them on COVID-19 potentially on there as well, is there anything else for November that members feel they would want to include in that meeting, or do you think there is sufficient items for that particular meeting?
I think that's sufficient. I don't know, what do other members think?
So if members are comfortable with that, then what my next question would be, is there any other items on the work programme that you would like to potentially get scheduled for this calendar year? So we've still got the December meeting, which hasn't got anything specifically on. So it's a case of putting forward any suggestions of there are any particular items they feel need to be covered for that December meeting. I think Leslie's got a hand up, Councillor Zaman.
Sorry, I know I'm being a pain, but health and social care, if as is looks like you're going to be having the workshop, and then there's also in theory something coming out of the government, because it's still all over the place, I would like that to be brought up as an item as soon as possible. I mean, ideally I would have, put it in October, November, but clearly I'm in a minority of wanting, if needed, longer meetings. It's not because I don't have other things to do, it's because I'm really passionate about this work and what's going on, and I'm really worried about what is happening.
My apologies. Just a point of order. I really think perhaps, Leslie, you mentioning that you're passionate. We all are passionate about the matter as well. However, it's not going to be suitable for everybody. So just kind of saying that we're not as passionate as you is perhaps not right.
I haven't said that.
Thank you.
At all.
It definitely felt that way.
Yeah. Dave, can I bring you in? You're waiting with your hand up.
Yeah, just in terms of maybe an item to consider this calendar year, and that is item 6, supportive care in Kirklees. It's been a while since we've had the CQC here. The last time they were here, there wasn't a chance to consider adult social care. And so it's a long time since we've considered adult social care in the CQC context. And maybe that's one item we could consider.
Mm-hmm. Yeah, we could look at that. Richard?
I'm perfectly happy to approach CQC to see if they would be available for the December meeting. So yes, I'm happy to do that.
Mm-hmm. Okay. Are you wanting to come back in, Councillor Lunat?
If we've got, I'm sorry, I do apologise. In terms of December, if it's already full, but something that I would like to put on is a look at our maternity and how COVID has affected our maternity wards with everything that's gone on. But that could be at a later date, but it's not on our work plan at the moment. Thank you.
Thank you. Richard, do you want to come back in?
Yeah, I mean, I think, as Councillor Lunat has said, we've not got that specifically down as a particular issue, although we have got, obviously, on item 2, the impact of COVID on the health and adult social care sector. Today we heard from the two hospital trusts, so we've got a real good feel for what's happening there in terms of their the impact on their services. But of course we were looking at the wider sector as well, so that it may be that we can maybe look at other elements of the health and social care sector and the impact on them. I mean, I can mention maternity as part of that, if possibly. That might be something that we could maybe sort of weave into that discussion. But I mean, it's really down to members in terms of whether they feel that's something that they would like to do at that meeting.
What do members think?
Well, I think by then we should have the final Ockenden report. We've had an interim one on Telford and Shrewsbury, and you know, there are all sorts of mistakes being made there, and that wasn't in COVID times. So we've not looked at maternity for quite a while. So if it could be worked in under the rubric that Richard mentions, I think it would be helpful.
Thank you, Peter. Councillor Bilama.
Yes, thank you. Coming back to future agendas, the area that I'm particularly interested in is the integration of health and adult social care, which is item 3 on the approach and areas of focus. We're skirting around it. We're talking about it in relation to COVID, etc. But it's actually a very, very important area. Because obviously different people have got different opinions on this. I personally think that adult social care and particularly elder care should be integrated fully with NHS service provision. It's an important area for debate, and I would like to see that I would like to try to make sure that we do find time to explore this in some depth. Thank you.
Thank you. David, waiting to speak.
Yes, just on item 14, air pollution, which I suggested maybe could be looked at. I just wanted to say it's quite an important issue, and it's got a public health dimension, it's got a respiratory health dimension, it links into environmental policies. And I just wonder whether there's scope perhaps to consider having a workshop jointly with the scrutiny panel that considers environmental issues to look at issues across the board in relation to air pollution, possibly.
Yeah, don't see why not.
Yeah, I can make contact with. I think that would be the Economy and Neighbourhoods panel. I think would cover that issue. So I think I can speak to colleagues who look after that panel, and obviously if there is an area there that they think is worth looking at, then yeah, we could potentially do. You're talking about a workshop, as in an informal session to sort of just start. Yeah, that's fine.
Thank you.
Yeah, we can look at that. And just going back to Councillor Armour's point, we will start that conversation, Councillor Armour, in relation to the November meeting where we've got the community care services discussion. So LACALA will be invited to that, as will the CCGs, and a lot of the work that they are doing is under the integration agenda. So we will definitely be starting that discussion. And going back to Leslie's point, I think obviously a lot of the integration agenda will be influenced by the bill that's currently going through Parliament. So maybe that's where we can maybe pick it up there, Leslie, if that makes sense. So we can maybe have part of that discussion around community services and that wider discussion about the overall impact that the bill will have on the integration agenda, because the commissioning landscape, as you all know, is going to change. So that's obviously going to have implications, and the governance structures in relation to the integrated care systems obviously will change as well. So whilst we're having a workshop on it, which I think is helpful because that just gives you the context and background and a bit more, and hopefully a greater understanding, I think it's important that the panel does have that public discussion as well, so that you've got that opportunity to debate publicly the implications of that bill and what it will mean to the integration of health and adult social care in our district.
Lynn, you have your hand up.
Thank you, Chair. Yes, just to say as well that currently there are the two projects, the proposals to merge the Gateway to Care service in Kirklees with the Locala single point of contact service, and the separate but linked project looking at the redesign of the direct payments process. And so coming a bit closer to home, I think they're all relevant as well, because those projects are ongoing now, and it would be useful to get an update on, you know, on how they're progressing. So that's just a thought from me.
I have, through you, Councillor Zaman, I have actually flagged that with Locala, and I did mention that that was something that we may want them to also highlight as part of the discussions when they come in November. I haven't mentioned about the redesigned direct payments. That will obviously probably come under the adult social care umbrella, but we can flag that with adult social care, and maybe we can sort of look to see if there's no, you know, from a timescale perspective, when would be appropriate time for that to come back to, you know, come to the panel for an update.
Well, thank you for that, Richard. If there's no further comments on that, can we bring?
I think Councillor Warner's got her hand up, has she?
Okay. Sorry, would you like to come in?
Yeah, it's just the mental health and well-being. I'm also concerned that, as you know, we've had funding as ward councillors to support young people in mental health, but that is no longer a priority for funding this next year. And it, you know, I'm just concerned that we weren't able to give all the support to the number of kids who requested it. So for me, that's also quite vital to be dealt with sooner than later. I appreciate that we can't do it all at the same time, but I just want to flag that up.
Your comments are being noted on that, Leslie. So thank you for that. That brings us to the end of the meeting this afternoon. I'd just like to say, in terms of the comment that was made by Councillor Warner, that everybody's comments are equally as important, and perhaps maybe better consideration needs to be made when making comments like that, so that, you know, we're all on equal footing. And public meetings, in terms of the panel members, you know, we're all giving our valuable time, and it's important and it's very valued. So thank you very much to everybody for attending and making valuable contributions, particularly to our co-optees, who put an awful lot of time into the meetings. So I'd just like to, you know, make it publicly on record that we are thanking everybody and valuing your input into the meetings. So that brings us to the end of the meeting, and thank you very much to everybody, and have a safe journey. See you next time. Thank you.
Thank you. Bye.
Thank you.
Thank you.